All right, is it go live now? All right. Hi, everyone. Thank you all for coming here for this another education session hosted by HCA Florida Healthcare. So here is another session. So first of all, I want to let you know, so all the episode of a video of an education session we have uploaded to YouTube channel. So if you're interested to review all the education session we had before, and you can subscribe to HCA Florida Healthcare YouTube channel. You can review all the education we provided before. So this is another session. The topic is constipation and hemorrhoids. So those are the two very common issues, and a lot of people get involved. So we can dig into it. Here we go. So first of all, I have no financial disclosure to report. I am an employee of HCA Florida Lake City Hospital. My name is E. Wong. You can call me Wilson. I'm a board certified general surgeon. This is our office, Lake City Surgical Specialist, located on US 90 Lake City. And if you have any question, you can call this number. We can provide all the help you need. Here you go. So constipation and hemorrhoids. So these two conditions actually very tightly related. Sometimes the chronic constipation, you have the strain, and then you develop a hemorrhoids. Sometimes you have a hemorrhoids because of the pain, and you cannot pass bowel movement easily, then cause the constipation. So let's dig into it. So the first is hemorrhoids. Sometimes the hemorrhoids could be small issues, but it can involve your daily life. You cannot work, cannot sit, cannot sleep, cannot eat, and it bothers your life. So we can study a little bit more and figure out how we can help you. So first of all, let's take a look at the anatomy. Based on the anatomy, we can look at the picture on the left side. That's the basic anatomy of the rectum. You see the, let me put on the lights. So look at on the picture on the left, that's the structure of the rectum. And in the rectum, we have sphincter muscles. And lots of blue dots, actually, you can see those are the venous plexus in this area. So there's a dentate line that's a structure in the rectum canal. If you see all these venous congestion dilated in the middle of that line, above that line, we call it internal hemorrhoids. And you see the picture lower, that's external hemorrhoids, is usually as the rectum, verge. So that's external hemorrhoids. So the other picture on the right side, you can see on the right side, those are more realistic picture. You can see those are bulgings from the dental line, those called internal hemorrhoids. And this is close to the outside of it, that's called external hemorrhoids. So as we talked about, hemorrhoids involve a lot of people. So by statistic number, up to 75% adults affected by hemorrhoids. So what are the risk factors? Including constipation, strain, prolonged sitting, a lot of women after pregnancy, aging, and low fiber intake. Those all the risk factor can cause hemorrhoids. What are the presentation of the hemorrhoids? So first is we look at the picture. A lot of people know this in rectal bleeding. So a lot of time there's a bright red rectal bleeding and could be a small amount. Sometimes could be continue going after the bowel movement. And anytime you notice there's some blood in the toilet or on the white paper, there's a fresh right blood, that could be hemorrhoids. A lot of issues we can talk about, other condition can cause the rectal bleeding as well. So the other thing most of the time bother people is anal discomfort or pain. Could be very severe pain, could last hours or whole day you have a lot of pain. So these are the two major symptoms. So the other thing is itching and irritation. Sometimes there's a little bulge in the rectum area and can cause itching and irritating. And a lot of time those are hemorrhoids. If it's a prolapsed internal hemorrhoids, you can see a little bulging outside the anus. That could be sometimes a prolapsed internal hemorrhoids, or sometimes it's just external hemorrhoids. So how do we diagnose a hemorrhoid? If you have the issue, you go see a doctor in the office. Usually we start with a history and a physical exam, and we'll take a look in a digital rectal exam, see if there's a bulging from inside or from outside, and we'll differentiate if it's internal hemorrhoids or external hemorrhoids. And sometimes we have to put a scope and take a look so we can differentiate internal hemorrhoids or external hemorrhoids.
Internal surge alert. Internal surge alert.
So the last, a lot of time, we will ask a patient to do a colonoscopy. And if a patient is greater than 45 years old, as we talked about, is likely need a screen colonoscopy to differentiate if the blood is from other source or only from the hemorrhoids. And if your patient has anemia and those are or some other reflex symptoms, we might consider get a colonoscopy to rule out other etiology. So let's take a look at the grade of internal hemorrhoids. So first is on the image all the way to the left, that's a normal rectum and anal canal. And there's no bulge and very smooth and internal lineum. So that's the normal, the rectum and anal canal. So second picture, this is called stage 1 hemorrhoids. You can see enlarged those venous plexus. This is a bulging, but the bulging still inside of the anal canal, and no prolapse. That's a stage 1. Stage 2 is that there's a prolapse from the internal hemorrhoids, but but you can easily reduce it spontaneously without manually help. So if you have a prolapse, you have to manually reduce it. So this is called a stage 3. And so the last picture on the far right is a irreducible prolapse. You can see the bulging is pretty big and stick it from inside out to outside, and it's not reducible prolapse. So this is a hemorrhoid is stage 4. Depends on which stage is, and the treatment will be different. We'll discuss after. So these are ugly-looking pictures. So these are just give you a very extreme example. So on the left side, this is a prolapse, a stage 4, significant internal hemorrhoids from inside out pushed out. It's not reducible, and a lot of time patient has a severe pain and cannot pass any feces, and you can see some necrosis on the top of the mucosa. So those are significant internal hemorrhoids at stage 4. And on the right side, you can see the picture is that's what we call the external hemorrhoids. We talk about the external hemorrhoids is so those are covered by skin instead of the mucosa. And this is extremely thrombosed and causes lots of pain. So that's thrombosed external hemorrhoids. So most of the symptoms from internal hemorrhoids, as we saw the pictures, those are the venous and congestion plexus in the internal of the rectal canal. A lot of time it can cause bleeding. And because external hemorrhoids is outside, those are covered by skin, you will more sensitive. And this is the pain related most of the time is external hemorrhoids. So thrombosed external hemorrhoids, like I said, it will cause a severe pain, acute onset. So if you go see an emergency room, if it's within the 72 hours, and most of the time we need to slice it, open up, evacuate the blood clots in the hemorrhoids, so it can give the best relief. If the patient has the symptoms of the external hemorrhoids longer than 72 hours, and usually we do conservative management. So like we're talking about rectal bleeding, there's a lot of things can cause rectal bleeding. Hemorrhoids is one of the reasons, but there's some red flags, and if can cause it by other issues. And sometimes they colorectal cancer, a patient had anal fissures, and inflammatory bowel disease, and especially symptom with a weight loss, anemia. If patient has a family history of a colon cancer or rectal cancer, those are the red flags you might have to see the doctor to eventually further workup and make sure nothing else. So what are the treatments you can do by yourself? So first is eat lots of fruits, vegetables, other foods with the fiber. And most of the time we recommend a 20 to 35 gram a day. So the picture on the right side just sort of give you an idea of what kind of food is the high fiber food. Some on the market and in the pharmacy you can get those fiber supplement. Those are some the listed Metamucil, citrusal, fibercon, benefiber. Those are you can get for fiber supplements. What else? Drink plenty of water, liquids, and especially important if you take a fiber supplement. And limit your food with a fatty food and alcohol, and those alcohol and fatty foods can make it worse. And take a stool softener, that's another way, and such as Dococet and Colace and Docolax. And also, when you have a bowel movement, take your time when you have a bowel movement, but do not spend too much time on the toilet if you have issues, and don't push hard in a string and when you have a bowel movement. And also doing a regular physical activity and gentle forms of exercise like walking, those are all good for your health. Another thing recommended if you go to ER or go to the office, usually we'll recommend warm sitz baths. That helps with the hemorrhoids. And sitting on the warm water with 10 to 15 minutes, twice or 3 times a day. And you don't have to put a soap in a bubble bath, just in the water. Sitz bath works by improving blood flow in the rectum. It relaxes all the muscle, and it can help with hemorrhoids. Some other topical agent, different kinds of creams and a suppository you can use, and you can get those from the pharmacy, can treat hemorrhoids too. And so most of these, you don't need a prescription. Some of the pain relief creams and hydrocortisone rectal suppository can help relieve the pain, inflammation, itching, and at least temporarily can control the symptom. And if the symptom is still not controlled, you might have to go see a doctor and sometimes refer it to surgeon if anything else we can do to help with your hemorrhoids. So we started with a minimal invasive procedure. So first is listed as a rubber band or ligation. So those are all as a minimal invasive, less bleeding, less the complication, but often used when we do with rubber band. So this is the picture on the right side. You can tell when we see the hemorrhoids, most of the so ligations are only used for internal hemorrhoids. We see the hemorrhoids sometimes used with the suction or grab. Use a forceps to grab the hemorrhoids and use the rubber band at the base of the hemorrhoids. So rubber band cuts off the blood supply of the hemorrhoids and cause the hemorrhoids to shrink and fall off eventually. So this is one way with a minimal invasive procedure. Some other could be sclerotherapy, injecting sclerosing agent into the hemorrhoids can treat the hemorrhoids too. So those are the two most often used for minimally invasive procedure. Some other procedure could be infrared coagulation, electrocoagulation. Those are all the other less common procedure to treat internal hemorrhoids. So more invasive is a excisional hemorrhoidectomy. That usually when we involve general surgeon, colorectal surgeon, we do hemorrhoidectomy. So we use the surgical way to remove internal and external hemorrhoids. So those mostly effective for large prolapsing thrombosed hemorrhoids, usually grade 3 to 4. Those are internal hemorrhoids. And we have to perform those under anesthesia. And after the anesthesia, compare minimal invasive procedure. This is a little bit longer recovery time. Some other procedure listed below, staple and Doppler guided artery ligation. Those are less commonly used. This is a picture just to give you an idea how we do the hemorrhoidectomy, excisional hemorrhoidectomy. Usually we'll put an anal scope there to find where the hemorrhoid is and find at the base and resect at the base. And because the incision we made, we have to close it up. So these are the pretty simple, straightforward procedure for hemorrhoidectomy. Before the procedure, if you see surgeon in the office, will plan for the procedure. A lot of time, if a patient you are using an anticoagulation, antiplatelet, those we call a blood thinner, we have to hold the blood thinner for a few days before the surgery, and to avoid the risk of a bleeding after the surgery. And about preparation, we don't have to do the whole colon preparation, but most of the time we'll recommend cleansing enema to just clean out the rectum before the procedure. After procedure, usually we recommend one is a pain management, because a lot of time after the surgery, first few days, you will experiencing considerable pain and swelling, and we'll recommend the supportive care, typically using the warm sitz bath, as we mentioned before, stool softener, and a pain medication, and sometimes we use the Tylenol and anti-inflammatory. Sometimes worsen the pain, will give you some narcotics. It is common after the surgery, the wound is open after 3 to 5 days, and sometimes you have a minimal mucus drainage from the area. However, if you have the symptom, high fever, significant erythema, bleeding, and persistent pain, then sometimes you have to go to ER, see doctor again to find out if you don't have any other complication after the procedure. So like we talk about the warm sitz bath after the procedure, we recommend it after the procedure, and the bath can diminish the anal pressure and relax the sphincter muscle almost up to the 70 minutes and relieve the symptoms. And we recommend it to take fiber supplement and increase the dietary fiber and increase the fluid intake. That will help to reduce post-op constipation. Most of the surgeons recommend a stimulant laxative and stool softener and a bulk fiber to prevent these happen, especially constipation after the surgery due to the pain. There's some complication after the hemorrhoidectomy, so especially for external hemorrhoids excision, and sometimes a minimal bleeding after the surgery. A lot of times it's less than 1%, and there's a less than 2%, and people will have the perianal abscess and a fistula. The most common complication is a recurrent hemorrhoids. So like you see the picture, if you develop a hemorrhoids was resected, does not prevent you have a more hemorrhoids developing. So sometimes the most common is recurrent hemorrhoids. Could be the same spot, could be a different spot. Internal sphincter injury is relatively very low, it's less than 1%. For internal hemorrhoidectomy, the most common complication are bleeding and a urine retention. And the rare complications are rectal perforation and sepsis, and sometimes very rare can cause rectal vaginal fistula and some minor changes of the incontinence. So let's move on. Constipation. Like we talked about, hemorrhoids can cause the constipation, and because the pain and a lot of time. A lot of time, constipation can happen after the hemorrhoids. So it's a pretty annoying situation. So like we talked about, constipation is a very common problem. And almost everyone in your life, you can involve at some point has a constipation once in a while, and it could be resolved on its own. So actually every year, more than 2.5 million Americans visit for constipation. So honestly, a lot of time, most common reason of abdominal pain is from constipation. So a lot of people ask, do I have a constipation? So these are a few things we can discuss, and then you can think about if you have involved the constipation, if you have those issues. And so we'll all talk about the feces or your stool. If your stool is too hard, that's constantly could be the issue. Or sometimes your stool is very small. Every time you push out, it's very small. And when you sit on toilet, it's very hard to get out the stools. And if the frequency is less than 3 times a week, that means you might have a constipation. And also frequently, you sit on toilet every time you have the strain, even eventually have the bowel movement out, but every time you have the strain, that's questionable possible you have a constipation. And every time if you sit on toilet, you can get out the stool without problem, but you still feel like every time after bowel movement, you feel like the bowel is still not emptying. So that could be constipation. So these are two different images and a CT scan. We look at on the left, and this is one of the CT scans. Seems like you see all these black bubble. These are the colon. That's the stool packed in the colon, and you can see those are that's what constipation. And on the right side is very extreme in the constipation. The whole bowel colon is packed with a stool. So how you develop those? A lot of time patient is confused. And I have a bowel movement every day. I don't have a constipation until symptoms get worse and worse and worse, and they go to see doctor, go to ER, and we had a CT scan, and we're diagnosed you have very bad constipation. But patient doesn't realize because they feel like I still have a bowel movement every day. Why it could be constipation, right? So there's a scenario I explained what that's why. So on the right side, there's a wine bottle, there's a cork is plugged in. Of course, you dump it out, there's nothing leaking because the cork is still there. Let's do this. If we push the cork all the way into the bottle, like the next picture showing, still plugged, right? So the wine bottle still plugged with a big cork in there, but you still have a leaking because all the way went in, all the wine is continually leaking. And if it's extreme, even the bottle all the way into the the cork is all the way into the bottle. In the inside, you still have the blockage, obstruction by the cork. But you know what? You still can have the leaking. So this is why a lot of people have a constipation, still have a bowel movement every day. So it's sometimes confused. I have a bowel movement every day, but patients still have a constipation. This is the example you to understand. If you have a bowel movement, but your bowel is not empty, and even have a bowel movement every day, does not mean you don't have a constipation. So what are the causes? So first is a dietary, low fiber, low water intake, pretty dry, and your lifestyle, sedentary behavior, and a lot of people take medication to avoid a bowel function, opiates, antacid, iron, antidepressant, and sometimes an overdose of a calcium supplement can cause the constipation. Some other medical conditions include diabetes and Parkinson's disease and hypothyroidism. So your bowels are not moving very well. In IBS, some people will have a pelvic floor dysfunction. Those are the most common causes of constipation. So other causes, we listed a few the categories right there. First is the motility, like we talked about. If you have a colonic inertia, pelvic dysphoria, and some nerve disease, and mechanical obstruction, and some tumor stricture. If you have prolapse, rectocele, and the diverticular disease, and those all can cause it. And metabolic disease, diabetes, if your calcium level pretty high and the potassium low, hypothyroidism, hyperparathyroidism, chronic kidney disease, those are metabolic disease can cause the constipation too. A lot of time we see the patient at home with a stroke and bedbound, and some patients have multiple sclerosis, Parkinson's disease, spinal cord injury, and myopathy, neuropathy. We see a lot of people with chronic constipation. Those drugs we mentioned about, all these opiates, the TCA, those can cause that. Some other condition listed here. Those are all the causes of constipation. So first of all, if you see the constipation, think about why we have the constipation. Figure out what's the cause. Treating the cause actually is the most important things of a constipation. So next, what other symptoms should I watch for? Not only the constipation. So these are the symptoms could be signs of other serious problem, not just because of constipation. If you see blood in toilet or paper after having bowel movement, if you develop fever, you have a chronic weight loss and a feeling weakness, and some other, like we mentioned about patient have a family history of a colorectal cancer, you have to go proceed the medical care in the office, your doctor and the surgeons. So if you have especially symptoms as a new, you're normal all the time, you never had issues. Now recently you have a constipation, severe constipation, is without the medication or diet change, and have never had a constipation before. Now you develop a severe constipation. You have to do further workup to make sure you don't have any other issues. So if you go see doctor, usually we do several tests. There's a rectal exam, see if it's because you have a pain, you have a big hemorrhoids, and you have a mass in the rectum, and so you constipated. And sometimes we have to do the sigmoidoscopy, put a camera and a colonoscopy and check all the colon to make sure there's nothing else cause your the constipation. Further imaging, X-rays and CT scan, MRI, those all the imaging can look inside the body to check if you have issues. If you don't have any other the pathological issues, sometimes we have to test your rectum function. And manometry is a test. It can measure the pressure inside your rectum at a various point. It can help to find out if your muscles in the rectum that control bowel movement are still working fine. So this is one of the studies we use usually by colorectal surgeon. We'll try to figure out if you don't have a cancer, don't have it like a mass, nothing else, we'll figure out it is your bowel and colon especially, and the transition is in the right, is working right. So this is one of study and to test if to test the bowel transition. So we give a patient to swallow those are small particles, multiple of them markers, could be different things, and those are be visualized under X-ray. So after you're swallowing those are little markers, usually after the 12 hours, those markers should be in your colon. So these are normal transition time. You swallow all the GI in the GI system and passing the stomach, small bowel, all the small particles should be in your colon around the 12 hours. But some study and some patient had issue, and so at the end of day 5, and the presence of fewer than 20% of those are markers or the particles suggest is a normal the chronic transition. So if more than 20% of those things in X-ray, still that means that you have a delayed chronic transition. So sometimes it's not mechanical obstruction blockage, it's just your colon is not transitioning very well. So these are the studies need to be done in a hospital. So for everyone else, do I need to go there? I don't have issues. Do I need to do that test to check if my colon has a transition issues? So you don't have to go to hospital. This is one easy study I can recommend. Everyone can do that. Even you don't think you have a colon issues. So this is another very easy test that can check not only colon, all your GI system, your stomach and a small bowel. So that's another test to see. It just check your GI transition time. So this is called white sesame seeds test. So it's a pretty straightforward. So instead of the like a medical test, we showed up, give you a small particle, we'll let you swallow a small amount of white sesame seeds. Right? So there's some steps. So first is a mix with a teaspoon of sesame seeds with a glass of room temperature water, and you drink it, mix it, and at the time, write down what exact time you swallow it. Then you start to monitor your bowel movements in the next few days to see when the sesame seeds started showing. And continually every day record it, and so they'll see the seeds in your stool and the last time you saw them. So that gives you a time range how it started to, so your bowel when you start to see the seeds and when you see the last time. So with all the data, so the ideal transition time is about the 12 to 24 hours. If your transition time is longer than 24 hours, that means you might have a slow digestion and might slow of your GI system. Not only in the colon, but you can tell you might have a slowly GI system. So this is a very simple test that everyone can do about. All right, so if you have a constipation, what can I do on your own before you see a doctor? Anything else I can help? So first, you will see the very similar, like when we help the hemorrhoids too. Eat foods with a lot of fiber, and a good choice of fruit and vegetable, prune juice, and the cereal. Those are listed in the picture. Remember when we talk about the hemorrhoids. And drink plenty of water and the fluids. And when you feel the need of have a bowel movement, don't hold it. And also try first thing in the morning and soon after the meal. So those are the time your bowel's more active. So at that time can help you pass bowel movement. And if you consider have slowly bowel transition, well, maybe you have mild constipation, take laxatives, and that helps to get rid of the bowel movement. Don't let it pile up and until you have severe constipation. And also get regular physical activity. Those are can help with your constipation too. Another thing that's my recommendation as well. A lot of people heard about the squatting potty position. So some people believe it, some people don't, but there's a scientific reason. Look at the picture on the right side. When you sit up a straight 90 degree on the toilet, so actually your rectum was a little bit choked by a muscle we call the puborectalis, those muscle in the rectum. Usually that's the muscle control your rectum. And but when you sit up like a 90 degree on the toilet, so this muscle actually choking the rectum does not help you passing bowel movement. So the one we can help is pull a little stool and put under your feet. So at that position, make your the leg and the thigh and your body, upper body, likely those angle and with a 35 degree, 45 degrees. And at that time, the muscle will relax and your rectum will be straight. This is a one-way position to help you to pass bowel movement. So everyone can try that. So how is a constipation treated? If you fail all the regimen, everything you can have. So if you come to hospital and so what we can give you, some other medication we can treat is a bulk forming medication. Those are metamucil, is a fiber medication. Of course, you need a lot of water with metamucil. And we can give you more aggressive osmotic medication, include Miralax, electrolytes, and those actually medication can drain all the fluids into the stool, make it your stool and soft and easy to pass. Some other stimulant medication is a short-term use. We can stimulate the bowel moving and push all the stool out. Docosed as another medication make the stool softer, and when you pass the feces, it could be helpful too. So some changing your medication and you take for other conditions, like we talk about if you're on pain medication, you have some other the antidepressant medication, those adjust your medication can be helpful too. And if your symptom continue to get worse, and sometimes need extra help, and that's when the time we use an animus. So animus can be just water, or they can contain some medicine, can help the constipation, and more like evacuate the stool from the rectum. Some biofeedback movement, there's another technique and you can learn and to relax your muscle so you can let go and push the bowel movement out. So at a very extreme condition, like sometimes I'll have to so manually disimpact all the stool in the rectum, and all the rectums is packed with a stool, and with manual disimpaction, some other condition we have to take patient under anesthesia and do the sigmoidoscopy, use an instrument, and we can get rid of the stool in the rectum. So when should I call the doctor? So we talk about all the constipation. Sometimes symptoms could be very mild, sometimes could be very severe. And so when your symptoms are new or not normal to you and continue happening, you want to figure out why you have the chronic constipation. You need to find out the reason. Like we talk about all the causes, you have to find out what other causes cause the constipation. And So, and sometimes you do not have a bowel movement for extensive time. And sometimes you feel like I'm doing okay, but I just the past week I have not had a bowel movement. And so you're not likely you won't need to see a doctor, and we'll probably have time sometime we'll have to do the imaging to figure out how bad the constipation is. And also constipation comes and goes, but lasts longer than 3 weeks. It's not resolving, no cause. You might have to see a doctor to figure out why and to help you with medication or something else. And if you develop a lot of pain, abdominal pain with constipation, you will have to go see a doctor. And if you have other symptoms and that worries you, sometimes bleeding, and at the same time you feel like weight loss, fever, and fatigue, weakness, and you will have to figure it out. And some people, they have a family history, colorectal cancer, inflammatory bowel disease, and with the constipation, I will recommend you go see a doctor to do further workup. So we talked about constipation and hemorrhoids at the beginning. So now we know those two conditions. So chronic straining, if you have a constipation, can cause a hemorrhoids. And treating the constipation may resolve your hemorrhoids symptoms. And the other way, treating the hemorrhoids can avoid the constipation. So these are the two very close conditions. So overall, like we talk about all these, so these are the common things, common thing you can do to prevent constipation or and hemorrhoids. So those are the your takeaway information. Summarizes here: high fiber diet and hydration, healthy bowel habits, and don't delay. You want to go have a bowel movement, don't delay, and avoid straining during bowel movement. Don't sit too long, and the limited time you're sitting on the toilet. And do physical activity, exercise regularly that can help your bowel movement. And like we talk about, your posture on toilet and squat potty position can help your bowel movement. With a medication awareness, and minimize all this medication can potentially cause constipation. And they use fiber supplements with water and also through softener that can help with the constipation and hemorrhoids. At the end is lifestyle choices, and avoid stress and change your lifestyle more active, and avoid drink, smoke. Those are the factors can avoid to prevent the constipation or hemorrhoids. So at the end, may we all poop like newborns, right? They don't have issue, no strain, no pain, no hemorrhoids. Whenever they want to poop, they will be on a diaper. So at the end, so this is our office, Lake City surgical specialist. This is number and address list down there. If we can provide anything to help you, and you can give us a call. So our surgical specialist will provide multiple other surgeries. Those are brief lists of what the surgeries we do. And gallbladder surgeries is a very common condition. And hernia repair include umbilical hernia, inguinal hernia, abdominal ventral hernia, some common GI surgeries, colon resection, appendectomy, diverticulitis. We talk about the hemorrhoids, and we do provide EGD and a screening colonoscopy. Some of the skin and soft tissue surgery we all provide. And in an emergency situation, we do surgery for bowel obstruction, gastric perforation, colon perforation. In a very rare case, we do sometimes in trauma surgery. We also do dialysis catheter, hemodialysis catheter, peritoneal dialysis catheter. So if you have any needs, just let us know. In my practice, my goal is to build a practice that is not just known for excellent surgery, but also for compassionate care, promoting health, healing, and wellness in the Lake City community. I want every patient to feel heard, respected, and confident they're in good hands. Lake City Hospital, and we provide all the home care you need and close to home. So at the end, just want everyone know this is education session. We put it on the Lake City Hospital Facebook page is a live stream, and it's also all the video we had before, and this video will be uploaded to YouTube channel. Just follow HCA Florida Healthcare you can review all the information we'll provide for healthcare education sessions. At the end, thank you all for coming, and all people watching on the live stream, and thank you all watching through the YouTube channel in the future. And I'm here to help like your neighbor. I look forward to serve you and your family in the years to come. Any question, everyone? All right, thank you for watching.